I am Dina. I'm one of the pharmacy residents here. Thank you for coming to today's CE. Today we're going to be talking about the management of alcohol withdrawal syndrome. So to get started, my disclosures, I have no financial interest or affiliation with any organizations that could be perceived as real or apparent conflict of interest in the context of this presentation. If I use any brand names, it's just for the ease of speech and identification purposes only. So our objectives today are to discuss the pathophysiology of alcohol withdrawal, recognize the time course of alcohol withdrawal symptoms, analyze the complications associated with alcohol withdrawal syndrome, define the different strategies involved in medicating patients presenting with alcohol withdrawal, and discuss the medications used for the treatment of alcohol use disorder. So to start out, I just want to give everyone some statistics. So 70% of Americans reported drinking within the past year, and more than 65 billion people are current binge drinkers. And the National Institute on Alcohol Abuse and Alcoholism defined heavy drinking as 4 or more drinks a day for males and 3 or more drinks a day for females. And 14.5 million people had an alcohol use disorder. More than 80% of those with an alcohol use disorder may experience withdrawal after being hospitalized. So the DSM-5 actually has an alcohol use disorder clinical diagnosis. So this is just for your reference. These are the questions they will go through to determine if someone actually has an alcohol use disorder. The presence of at least 2 of these symptoms indicate alcohol use disorder. Mild alcohol use disorder is 2 to 3 symptoms, moderate is 4 to 5, and severe is greater than 6 symptoms. It's important to note that alcohol use disorder is a clinical diagnosis, and extensive testing may be needed to rule out any other diagnoses that can mimic or coexist with alcohol withdrawal. This can be infection, trauma, metabolic derangements, drug overdose, hepatic failure, and GI bleeding. So it's very important to make sure we're diagnosing these people correctly so we can correctly treat them. This carbohydrate deficient transferrin is actually the most specific serum marker for heavy alcohol consumption. So this would be a great indicator to use on all patients coming in with suspected alcohol withdrawal. So CDT refers to a temporary alteration in the glycosylation pattern of transferrin, and this results in an increase in the relative amounts of diacetyl and acetyltransferrin. And this occurs as a result of sustained heavy alcohol consumption. And these levels don't return to baseline levels until about 2 to 5 weeks after complete abstinence from alcohol. So this is a great indicator to determine if they have been chronically using alcohol. They might present with a blood alcohol level of 0, but if they have this marker, it means within the past 2 to 5 weeks, they were heavily consuming alcohol. The problem with this, it has an extremely low sensitivity. So falsely low CDT levels are seen in heavy drinkers who are women, who have cirrhosis and have metabolic risk factors such as obesity, insulin resistance, hypertension, or dyslipidemia. These patients usually have an elevated BMI. So that the low sensitivity is really what limits the use of this, but it is super specific to heavy alcohol consumption. So I just wanted to start with a patient case question. A 65-year-old male with no past medical history, hasn't seen a doctor in 30 years, presents to the ED complaining of not feeling well. No pain, I just feel bad. In the ED, he denies prior episodes and presents with palpitations, diaphoresis, mild shortness of breath, shaky, nervous, and nauseous. He denies alcohol use, stating, I stopped 1 day ago because my wife had been asking me to quit for years. Before this, he was drinking 1/5 of whiskey per day. Which of his presenting symptoms are likely due to alcohol withdrawal? This is just to gauge if we can kind of identify possible symptoms. You can put in the chat or you can unmute yourself, whatever you want to do. Yes, E. Thank you. So all of these are classic symptoms of acute alcohol withdrawal. So I'm going to dive into now the actual metabolism, just a little review of what happens when we drink alcohol. So this is the alcohol metabolism pathway that is in our body. Alcohol and ethanol are going to be using interchangeably. So this occurs, the first step, ethanol into acetaldehyde occurs in the cytosol, and then acetaldehyde to acetate occurs in the mitochondria. So it's important to note that both of these enzymes, alcohol dehydrogenase and aldehyde dehydrogenase, follow zero order kinetics, meaning there's a constant elimination regardless of how much ethanol is consumed. So this pathway can get supersaturated very quickly. It's also important to note the cofactors NAD+ and NADH that are used in both of these enzymes. So when we drink too much alcohol, we actually deplete a lot of the body's NAD+, and we accumulate a lot of NADH. So these cofactors are used in a multitude of metabolic processes in the body. So this alcohol pathway can actually influence other metabolic pathways in the body. It's also important to note that acetaldehyde is what is toxic, and it can spread to the blood and cause systemic issues or stain to the liver and also cause issues. This produces the symptoms of a hangover. And a buildup of this also actually induces a catecholamine release. And then the byproduct of this whole pathway is acetate, which can be converted to acetyl-CoA, which is also used in other metabolic pathways in the body. That pathway follows zero-order kinetics. So once it gets supersaturated, we do have the secondary pathway that the body can use to break down ethanol. The problem is we have to use CYP2E1. And CYP2E1 creates a lot of reactive oxygen species that can cause more damage to multiple organs, but especially in the liver. And this is about 10% of ethanol metabolism. But it's important to note that CYP2E1 actually becomes upregulated in chronic alcohol users. This can contribute to the tolerance that we see when people chronically use alcohol, and can also contribute to the liver damage that comes from chronically drinking alcohol. So like I said, just a little review, that pathways, both of those pathways can cause other consequences. So it can cause dysregulation of glycolysis, and this is due to not enough NAD+. It can cause increased lactic acidosis, and this is because pyruvate will be converted to lactate to try to use up more of that NADH that we're using, that we're producing from the alcohol pathway. It can alter the Krebs cycle, and this is due to a buildup of acetyl-CoA and too much NADH, and the body will actually try to convert to ketosis to try to use up some of the acetyl-CoA. So this is why a lot of patients with chronic alcohol use will present with ketones in their urine. It can also cause a suppression of gluconeogenesis. So this is also why patients might present with a fasting hypoglycemia. And this is because of too much NADH. We can't convert pyruvate to glucose, so this leads to hypoglycemia. And lastly, this can suppress fatty acid oxidation. And this is due to the high levels of acetyl-CoA. And this is what can lead to an accumulation of triglycerides and ultimately leads to fatty liver disease. So that was just a little review of the metabolic pathways and the breakdown of alcohol. Now I wanted to get into what's happening in the brain when we drink too much alcohol. And this is mainly an imbalance of GABA and glutamate. So GABA is the major inhibitory neurotransmitter in the CNS. Glutamate is one of the excitatory amino acids in the CNS. And they kind of work opposite each other to create a homeostasis in everybody. So in a non-alcoholic, we have a nice balance between GABA and glutamate, and we can function fine. With occasional alcohol use, alcohol actually binds to the GABA receptors and can potentiate it. And that's what causes the suppressive effects of alcohol. But the body will compensate for this. Once we stop drinking, it'll rebalance once the alcohol comes off of the GABA receptors, and we're okay. The problem is with chronic and regular use of alcohol, because there's constantly alcohol binding on the GABA receptors, the body kind of compensates and says, okay, we have enough alcohol coming in, we can kind of downregulate our GABA receptors, but the body will also upregulate the glutamate receptors to counteract that. And this is just the way of the body to try to achieve that homeostasis that we had when we weren't drinking alcohol. This creates a problem if we have that withdrawal, if we have that we stop the alcohol coming in. Now we have upregulated the glutamate and downregulated the GABA, and this causes a hyperexcitatory state. And this is what can precipitate all the severe side effects of alcohol withdrawal, such as seizures or delirium tremens. So this is really the issue. This is really the mainstay issue with alcohol withdrawal, the imbalance of GABA and glutamate. There are other pathways that are affected in the brain from chronic alcohol use. So like I said, GABA and glutamate, but then also the dopamine and opiate systems are also affected. So GABA and glutamate are involved in alcohol stimulation, sedation, and intoxication, and this is what precipitates the signs of alcohol withdrawal. The dopamine and opiate systems are involved with the reinforcement, the reward, the craving of sustained alcohol use, and this is what causes a potential relapse after prolonged abstinence. So the body creates this reward system after drinking alcohol, and this is what leads people to want to drink more. So now let's dive into the withdrawal timeline and symptoms. So without treatment, symptoms can begin within 6 to 24 hours after the last drink or sudden reduction in chronic drinking. So these symptoms, the onset and duration of these symptoms depends on the severity of the syndrome. So it depends on how much they've been drinking and for how long they've been drinking these quantities. So minor withdrawal can occur in 6 to 36 hours. And this is the tremors, the mild anxiety, headache, diaphoresis, palpitations, GI upset, but these patients still have a normal mental status. Then seizures can present within 6 to 48 hours after that last drink. And these are usually single or brief flurry of general tonic-clonic seizures. Next, we have alcoholic hallucinations. They occur in 12 to 48 hours after the last drink. These can be visual, auditory, or tactile hallucinations, but it's important to note at this step, these patients still have normal vitals and a normal mental status. They're fully aware of the fact that they're hallucinating. Then the most severe symptom of alcohol withdrawal is delirium tremens. So this is when occurs in 48 to 96 hours after that last drink. And it's where we have the delirium, the agitation, tachycardia, hypertension, fever, diaphoresis, and this can ultimately lead to a coma as well. These patients also, aside from the symptoms, will also present with fluid and electrolyte abnormalities. So a lot of these patients present and they're hypovolemic, and this is from the diaphoresis, hyperthermia, vomiting, tachypnea, and decreased oral intake from just chronic alcohol consumption. They also will present with hypokalemia, and this is due to renal or extrarenal losses, alterations in aldosterone concentrations, and changes in potassium distribution across the cell membrane. They also can present with hypomagnesemia, and this is common in patients who develop delirium tremens, and it actually predisposes the patients to dysarrhythmias and seizures. And they also commonly present with hypophosphatemia, and this is more related to the fact that a lot of these chronic alcohol users are malnourished, and this can also contribute to cardiac failure and rhabdomyolysis. So I just wanted to touch on delirium tremens a little more. So like I said, this is the most severe alcohol withdrawal complication. It can last for 5 to 7 days, and even with treatment, there's a 5% risk of mortality. Risk factors for developing this, so it depends on whether they've had a previous history of delirium tremens, if they're older than 30, if they have concurrent illnesses, sustained drinking, withdrawal with a positive blood alcohol level, or if there's been a longer period between their last drink and the onset of withdrawal. And this delirium tremens, like I said, it's hallucinations, disorientation, hypertension, hyperthermia, diaphoresis, all of these severe symptoms, and it can also lead to coma and death. So this is what we're trying to prevent when we're treating these patients with alcohol withdrawal. We do have this predictor of alcohol withdrawal severity scale, the PAUSE score. So this is used to just try to predict how severe the patient's withdrawal is going to be. There's 3 parts to this score. So part A is the threshold criteria. And this is just, has the patient consumed alcohol within the past 30 days, or if they're presenting with a positive blood alcohol level on admission. If either one of those is yes, then you can proceed with the rest of the scale. Part B is the patient interview. It's 8 questions, and they're similar to the questions used on the DSM-5 criteria to determine whether they have alcohol use disorder. And then part C is the clinical evidence. So if they present with a blood alcohol level greater than 200 on admission, or is there any evidence of increased autonomic activity? And this can be heart rate of 120 beats per minute, tremors, sweating, agitation, nausea, any of these symptoms qualifies as autonomic activity. The max score is 10, but any score greater than or equal to 4 indicates a high risk of moderate to severe alcohol withdrawal. So now let's dive into the alcohol withdrawal syndrome management and treatment. So for an overview, we want to treat the psychomotor agitation that is resulting from the imbalance of GABA and glutamate, supportive care with IV fluids and nutrition supplementation, and frequent clinical reassessment. So the goal of therapy is directed at alleviating symptoms and identifying and correcting any metabolic derangements. The big thing here is we want to prevent progression into more severe withdrawal. So first up is benzodiazepines. These are the gold standard psychomotor agitation treatment for alcohol withdrawal syndrome. Benzodiazepines are what is going to prevent the progression from minor withdrawals into major withdrawal symptoms. Benzodiazepines work by stimulating GABA receptors, causing a decrease in neuronal activity and a relative sedation. It's also important to note that all of these are hepatically metabolized. So like I was going into before, chronic alcohol use can cause liver damage. So it is important to note that we're using a medication that is hepatically metabolized, so we have to take that in consideration when we're choosing which benzodiazepine to give. If the patient has no other underlying issues and their liver function is fine, ideally we want to use a long-acting benzodiazepine with an active metabolite. So that's going to be diazepam or chlordiazepoxide. These are preferred because they create a smoother clinical course and they have a lower chance of recurrent withdrawal or seizures. they actually allow for a self-tapering effect. So these are most beneficial for these patients. If patients are presenting with advanced cirrhosis or acute alcoholic hepatitis, then we're going to want to use a shorter acting benzodiazepine with no active metabolites. So that's going to be lorazepam or oxazepam. And this is because if they have that liver damage, if we use a benzodiazepine that's long acting and has metabolites, it's just going to cause oversedation and create prolonged effects that we don't want here. So that's going to help decide between which of the benzodiazepines we use. They come in a bunch of different formulations. It's important to note that Librium and oxazepam are only capsules, so those can only be given to patients who can take something orally. Diazepam comes in multiple different formulations, although IM is not given because of the variable drug absorption. So we're more likely going to be giving IV diazepam. And then lorazepam comes IV, IM, and also as an oral form. But it's important to note that IV lorazepam is formulated with propylene glycol, and repeated administration could lead to metabolic acidosis from propylene glycol toxicity. So if we're going to be giving IV lorazepam, we have to closely monitor these patients for any signs of toxicity. And this should be considered if a patient develops an unexplained anion gap, unexplained metabolic acidosis, hyperosmolality, and or clinical deterioration, and they're just not improving even though we're giving them benzodiazepines. This is when we might want to switch to something else. That's why IV lorazepam really isn't used as much. We are more likely to give it IM. So oral formulations are preferred for outpatient use. So sometimes alcohol withdrawal can be monitored on the outpatient setting if it's not as severe. That's when we were going to give more of an oral formulation. So this is just our benzodiazepines. There are different treatment strategies for the benzodiazepines. So we have front-loading therapy. So this is recommended for patients who are at greater risk of experiencing dangerous complications should they develop severe withdrawal. So this is for patients who are likely to be harmed by prolonged periods of hypertension or tachycardia. These are patients who are frail, older adults with underlying cardiovascular disease. And the whole idea behind front-loading therapy is to achieve heavier sedation very rapidly and then closely monitor their sedation from there. So this is usually, we give diazepam 5 to 10 milligrams IV to 5 to 10 minutes until sedation is achieved. You can also use the lorazepam, but again, we have the risk of the propylene glycol, and you have to wait 15 to 20 minutes between each dose. So that longer wait period between dosing is not ideal. So we'd rather give diazepam. Then we have fixed schedule dosing. So this is when benzodiazepines are given at a fixed interval, even if symptoms are absent. This is most useful for patients who are at risk but are asymptomatic or minimally symptomatic at the moment. This also requires frequent reassessment because we don't want to oversedate them. And it is also important to note that the fixed schedule therapy also does have PRN benzodiazepines on board as well, because they might need an extra dose in between their dosing schedules. Lastly, we have symptom triggered therapy, which is actually preferred for most patients if we can. So it does require regular systemic assessment of the patient's status using a validated instrument. So this is when we would use the Clinical Institute Withdrawal Assessment for Alcohol, or the CWAS scale, or the Richmond Agitation Sedation Scale. So the CWAS scale, which I have here, is preferred for most patients. It looks at 10 different aspects of alcohol withdrawal. There are modified CWAS scores as well, but this is the true CWAS scale. So they look at nausea, vomiting, tremor, anxiety, agitation, proximal sweat, orientation, tactile disturbances, auditory disturbances, visual disturbances, and headache. So we evaluate these patients as when they first come in. It can be as frequent as every 10 to 15 minutes. And then once their symptoms are controlled, we'll do it more hourly. And then once they're super controlled, we can even go to every 4 to 6 hours. The scoring scale, so less than 10 is very mild withdrawal, 10 to 15 is mild withdrawal, 16 to 20 is modest withdrawal, and any score greater than 20 is severe withdrawal. It's also important to note that any score greater than or equal to 8 warrants additional medications be given if we're using that symptom-triggered therapy. But the problem with this scale is a lot of these questions are, they need to be answered by the patient. So the patient has to be cognitively intact if they're able to answer some of these questions. So some of these patients who come in and they're super severe and have to be sedated, possibly endotracheally intubated, or put on mechanical ventilation, we can't use the COS scale because we can't answer the questions, they can't answer them. So that's when we would use the RASS scale, the Richmond Agitation Sedation Scale. So like I said, it's used for patients who are intubated and they can't answer those other questions, or if they're just not cognitively intact. So a severe score is greater than 30. The goal for these patients when we're giving them medications is to have them between 0 and -2. So here I have another patient case question. A 28-year-old male presents to the ED with signs of alcohol withdrawal. The patient states that he hasn't had a drink in 18 hours, but drinks heavily on a daily basis. He has no pertinent medical history or surgical history. Which of the following is a key part of the plan for this patient's treatment? I'll give you guys a second. Yes, B. So we want to continuously monitor the vitals because as of right now, this patient doesn't have any alcohol withdrawal symptoms, but we know they can occur, depends on how long since the last drink, but it can occur up to 36 hours after the last drink. So our whole thing here is to monitor him and try to be on top of the withdrawal symptoms before they occur so he doesn't progress into severe withdrawal. Good job, thank you. So here's a study I found that compared symptom triggered versus fixed dose of benzodiazepines for alcohol withdrawal. The objective of this study was to determine the benefits of an individualized treatment regimen on the quantity of benzodiazepine administered and the duration of its use during alcohol withdrawal treatment. This was a prospective randomized double-blind controlled trial, including 117 consecutive patients with alcohol dependence. 56 patients were treated with oxazepam in a symptom-triggered fashion, while 61 were treated with oxazepam Q6 hours with additional doses PRN. The outcome of the study was the total amount and duration of treatment with oxazepam, the incidence of complications, and the comfort level. The conclusion of the study found that symptom-triggered benzodiazepine treatment for alcohol withdrawal is safe, comfortable, and associated with a decrease in the quantity of medication and the duration of treatment. So this was the results from this study. Both groups were similar in age, sex ratio, ethnic makeup, marital status, employment, all of that. This study found that symptom-triggered patients saw a significant reduction in the duration and quantity of oxazepam used during alcohol withdrawal. It was about 6 times less oxazepam than the fixed dose group. They also saw that the symptom-triggered group had a shorter duration of treatment. They did have higher CWAS scores, which is as to be expected, because if we're giving the fixed dose people doses every 6 hours, we're kind of covering the symptoms before they're occurring. Whereas the whole point of the symptom trigger is we're waiting for them to have the CWAS scores to give them their medication. The big thing from this that I took away was of the 56 patients who were in the symptom triggered group, only 22 actually required a dose of oxazepam. So that's significant because the majority of the patients who were in the symptom triggered group didn't even need any medication for their withdrawal. This study also found that there were no treatment group differences in health concerns, anxiety, energy, or depression. The other takeaway from this study that I found was there was one incidence of seizure in the symptom triggered group, while the fixed schedule group had no major complications, which was seizures, hallucinations, or delirium tremens. That was also a takeaway. By waiting for these patients to have their symptoms, we do put them at a risk of progressing and having these severe complications. Next, I want to talk about refractory delirium tremens or resistant alcohol withdrawal. This may be present if symptoms of severe alcohol withdrawal are not controlled adequately after the IV administration of more than 50 milligrams of diazepam or 10 milligrams of lorazepam during the first hour of treatment. If this is the case, this is when we're going to go to a medication such as phenobarbital or propofol. Phenobarbital also works on GABA channels. It helps to open them more frequently and also has some effect on NMDA receptors. This used to be the treatment of choice for alcohol withdrawal syndrome before we all switched to benzodiazepines. It's not indicated for monotherapy. So if they do have this refractory delirium tremens, it's going to be used in conjunction with benzodiazepines for the synergistic effects. There is a greater risk of cardiovascular and respiratory failure when we have to use phenobarbital. The other drug that we might use is propofol. So propofol acts to open chloride channels in the absence of GABA and may antagonize the excitatory amino acids that are upregulated during alcohol withdrawal. It's important to note that when these patients become resistant to alcohol withdrawal, these patients are more likely to be intubated and be on mechanical ventilation. So it's unsure if it's because of the alcohol withdrawal or because we're having to use these other medications that they kind of decline into needing mechanical ventilation, but it is important to note. So this next study I have was a prospective randomized trial of phenobarbital versus benzodiazepines for acute alcohol withdrawal. So the objective of this study was to compare phenobarbital versus lorazepam in the treatment of alcohol withdrawal in the ED and then at 48 hours. It was prospectively randomized. Consenting patients were assessed using a modified CWAS score and given IV phenobarbital or lorazepam. At discharge, the lorazepam patients received chlordiazepam epoxide and the phenobarbital patients received placebo. The outcomes was to compare IV phenobarbital versus IV lorazepam plus oral chlordiazepam epoxide in the treatment of acute alcohol withdrawal with regard to efficacy of symptom amelioration during the ED stay and then at the 48-hour reassessment, the length of ED stay, and the final disposition and the relapse rate. In conclusion, this study found that phenobarbital and lorazepam were similarly effective in the treatment of mild to moderate alcohol withdrawal in the ED and then at 48 hours. So these are some of the charts of the results from the study. Of the 44 patients, 25 received phenobarbital and 19 received lorazepam. Both of these patients saw reduced CWAS scores from baseline to discharge. The study found that there was no difference between phenobarbital and lorazepam in baseline CWAS scores, in discharge scores, in the ED length of stay, on admissions, and the 48-hour follow-up CWAS scores. This study was kind of showing that there was no difference between phenobarbital and benzodiazepines. This is why there is still some kind of controversy between which one is better. As of right now, guidelines are still saying benzodiazepines are better, but more studies, more bigger studies are needed to really determine which one is better. So lastly, for treatment, we have supportive care. So on top of the benzodiazepines for the psychomotor agitation, we want to also give isotonic IV fluid until the patient is clinically euvolemic. Like I mentioned before, a lot of these patients are hypovolemic when they are first admitted into the hospital. Then a lot of treatment is IV at first when these patients come in because their GI absorption is usually impaired if they chronically abuse alcohol, and they're often kept NPO to prevent aspiration when they first come in. We're also going to give thiamine and glucose, and this is to prevent or treat Wernicke encephalopathy, which I'll dive into a little later when I go over the complications. We're going to also give multivitamins and folate. So again, these patients are usually malnourished when they are presenting. Any electrolyte deficiency should be corrected as needed, and then nutrition support. So again, just to drive home the point, a lot of these patients are malnourished, but they also have high metabolic needs due to the excited autonomic state that they're in. So nutrition support is super important for these patients as well. I wanted to go over some alternative or contraindicated agents. So these are other drugs that have been used in conjunction with benzodiazepines. They are less well studied and should not be used routinely for moderate to severe alcohol withdrawal. This is because they tend to mask the hemodynamic signs of withdrawal, which can precede seizure. So we don't really want to mask these symptoms because we want to treat these symptoms to prevent us from getting to those severe symptoms such as seizure and delirium tremens. So first off, I have ethanol. It sounds like it would be a good idea, but it's actually not. It's difficult to titrate, and it's associated with many adverse metabolic and end organ effects. So we really would never give ethanol for alcohol withdrawal patients. Next, we have antipsychotics. So phenothiazines and buprenorphine actually lower seizure thresholds. And we know these patients are at risk of developing seizures, so we wouldn't want to give these. They also interfere with heat dissipation and do not exhibit cross tolerance with ethanol. These are only indicated when the patient also has some kind of underlying psych disorder, such as schizophrenia, that's coexisting with the alcohol withdrawal, and the withdrawal is being controlled with benzodiazepines. If they are used in these situations, EKGs are needed to monitor for QT prolongation, and it's super important that we're correcting those electrolyte abnormalities before medications are administered, because these again can cause precipitate any arrhythmias or QT prolongation. Next, we have anticonvulsants. So anticonvulsants actually have no role in alcohol withdrawal seizures. Alcohol withdrawal seizures are usually self-limited and do not require anticonvulsants. If these patients develop status epilepticus, this is when we're going to use phenobarbital or propofol for a short time in conjunction with benzodiazepines before we're going to use any other kinds of anticonvulsants. There is some evidence, I have on the slide here, carbamazepine, gabapentin, and valproic acid. There is some evidence that these can be used in the outpatient setting for outpatient alcohol withdrawal. But again, more studies need to be done to really determine if these truly are worth giving for patients who are withdrawing on the outpatient setting. Next, I have centrally acting alpha-2 agonists. So as of now, these are not recommended for alcohol withdrawal. There has been more studies coming out, and we need more studies to come out regarding this. Still, we are seeing an increase in the use as adjunctive therapy for alcohol withdrawal, and this is due to some studies showing that they do decrease benzodiazepine requirements, and they may reduce some symptoms of withdrawal. But they are associated with an increased cost and more episodes of bradycardia and hypotension. So these really are not supposed to be given for alcohol withdrawal, and I have a few slides coming up to dive in a little more. And then beta blockers. So these may reduce minor symptoms of withdrawal, but they do not prevent the progression into seizures or delirium tremens. So that's the real mainstay treatment for alcohol withdrawal. We want to prevent the progression into more severe alcohol withdrawal, which all of these medications will not do. Beta blockers can be given as maintenance medication if the patient is already on it for some kind of other cardiovascular indication, but these should only be given after sedation has been achieved and these patients have been volume resuscitated. And this is because sustained tachycardia and hypertension may contribute to cardiovascular morbidity. So we want to prevent that if these patients need to be on it for another reason, but we're not going to be giving it to someone for alcohol withdrawal. This next study I have was a randomized double-blind placebo-controlled dose range study of dexmedetomidine as adjunctive therapy for alcohol withdrawal. So this study, the objective was to evaluate dexmedetomidine as adjunctive therapy to lorazepam for severe alcohol withdrawal. It was a prospective randomized double-blind placebo-controlled trial of 24 patients with a CWAS score of greater than 15, despite greater than 16 milligrams of lorazepam over a 4-hour period. Patients were randomized to receive dexmedetomidine as a high dose, as a low dose, or they were given placebo as adjunctive therapy for up to 5 days or until the resolution of their withdrawal symptoms. The outcome was the change in total lorazepam requirements over a 24-hour period after starting the study drug compared to the 24-hour period before the start of the study drug and the cumulative lorazepam dose over the first 7 hospital days of alcohol withdrawal. This study found that adjunctive dexmedetomidine for severe alcohol withdrawal maintains symptom control and reduces lorazepam exposure in the short term, but not in the long term when using a symptom-triggered protocol. So this was their primary and secondary efficacy endpoints, the results of the study. The difference in the 24-hour lorazepam requirements after versus before study drug was greater in the dexmedetomidine group compared to the placebo group. And the 7-day cumulative lorazepam requirements were not significantly different between the dexmedetomidine group and the placebo group. This really showed, it really didn't show a benefit of using it. I did want to point out the adverse events though, because all of the patients who received placebo versus the dexmedetomidine, bradycardia occurred more frequently in the dexmedetomidine group. And this was a majority of bradycardia occurring in the high dose group, especially. It is important, and with the study, they also said that neither endotracheal intubation or seizure occurred in any group while on a study drug. But it is important to note that this bradycardia, hypotension, decrease in heart rate was all more prevalent in the treatment group versus placebo. So this was really showing that there wasn't really a benefit in the benzodiazepine usage, and it just caused more side effects. So it's really, these essentially acting alpha-2 agonists shouldn't be used for alcohol withdrawal. And that's because these can mask the adrenergic signs of alcohol withdrawal. So that's the tremor, the agitation, anxiety, and tachycardia. So that thought process of using less benzodiazepines is because these patients are having a decreased CWAS scores, because tremor, agitation, anxiety are some of 3 of the 10 aspects that we look at when we're doing the CWAS score. So if we're masking them, they're not having this, we're not going to give the benzodiazepines, but these aren't actually acting on what's causing the symptoms, which is the imbalance of GABA and glutamate, which is why benzodiazepines are the mainstay of therapy, because they're actually treating the root problem of what is precipitating these symptoms. So dexmedetomidine really shouldn't be used for alcohol withdrawal. I have another patient case question. So a female hospitalized for pneumonia reports regular heavy ethanol use, but has not consumed any since admission 16 hours earlier. She complains of nausea, insomnia, and appears tremulous. Which of the following measures are indicated? Give everyone a second again. D, yes, D is the answer here. We're going to be giving the benzos, the IV fluids, and replacing any electrolytes that may be needed at this time. I saw the answer A, propranolol. So like I said, beta blockers would not be given for alcohol withdrawal. which is likely what is happening in this situation here. So now let's go into some complications and the treatment. So complications can span from stroke, head injury, Wernicke encephalopathy, alcoholic liver disease, which is steatosis, alcohol hepatitis, alcohol cirrhosis. These patients can also have infections in the CNS and systemically, complications secondary to diabetes and hypertension, and metabolic encephalopathy due to imbalances in the electrolytes. So Wernicke encephalopathy is probably the most commonly associated complication, but its incidence is actually pretty low. This is an acute and reversible encephalopathy due to a deficiency in thiamine, which is vitamin B1. So thiamine is required as a cofactor for several enzymes used in metabolic pathways. So it kind of makes sense because these patients have this malnutrition. We suspect that they also be deficient in thiamine, and they also are presenting with signs of encephalopathy sometimes due to the altered mentation. So we want to try to prevent this because it can occur, but it's actually not as common as we may think. It occurs in patients with poor nutrition absorption, intake, or loss, so in alcoholism, but also in patients with anorexia, GI surgery, malignancy, dialysis, and HIV and AIDS. So symptoms of this is confusion, so they'll have profound disorientation, indifference, and inattentiveness. They also will present with ataxia, so their stance and gait will be altered. Usually they'll have a wide-based gait with slow, short-spaced steps. They'll also usually present with polyneuropathy. Ocular dysfunction is also common, so they'll have nystagmus, bilateral rectus palsy, sluggish pupils or anisocoria, which is unequal pupil sizes. In terms of treatment, so this is why we're giving thiamine and glucose. If they truly have Wernicke encephalopathy, we're going to treat with high dose, so that's 500 milligrams IV 3 times a day for 1 to 2 days, and then we transition to 250 milligrams IV for once a day for 5 days. It's important to note we also give glucose, but the order that we give it is important. So we're going to give the thiamine before we give the glucose, and that's because it is used as a cofactor for these metabolic pathways. So if you give glucose before you give the thiamine, it actually can make the Wernicke encephalopathy worse. So we want to give the thiamine so it can help with those processes, and then give glucose so the processes can actually use the glucose. The reason we're worried about Wernicke encephalopathy as well is it can actually progress into Korsakoff syndrome, which is irreversible neurologic damage. So Wernicke is reversible if we give the thiamine back. So we preemptively give all these patients thiamine just in case. Next, we have alcoholic liver disease. So this depends on the quantity and duration of the patient's alcohol intake. That's the highest risk factor for development of liver disease. So first we have steatosis or fatty liver. And this is due, like I said before, too much alcohol can interrupt fatty acid oxidation. So triglycerides will accumulate in the liver. Patients who are also obese or have a fatty diet can also increase their risk of developing this fatty liver. It is reversible. So all of alcohol liver disease at this point is reversible if they stop drinking. So alcohol abstinence is the mainstay treatment for alcohol liver disease. We also will give nutrition support, but if they continue to drink, this will lead to alcoholic hepatitis. So this brings the immune system into play, and actually interleukins and neutrophils attack hepatocytes, and this causes swelling and ultimately hepatocellular necrosis. Still at this point, it is reversible if you can get your patient to stop drinking. But if they don't and it progresses to alcoholic cirrhosis, this is now irreversible liver damage and liver fibrosis. At this point, stopping drinking will not reverse this. The only treatment here is surgical removal or transplantation. The alcohol liver disease can also cause more complications such as variceal hemorrhage, ascites, spontaneous bacterial peritonitis, which is an infection of that ascites fluid, hepatorenal syndrome, hepatic hydrothorax, hepatopulmonary syndrome, and hepatic encephalopathy. So as you can see, if you can stop the patient from drinking, it'll prevent all of this from happening. Lastly, I want to go over some FDA-approved medications that help stop or reduce drinking and prevent relapse. So patients who complete withdrawal are actually at high risk of relapse and resuming alcohol consumption. So first we have naltrexone, which is a pure opioid antagonist that modifies the hypothalamic pituitary adrenal axis to suppress alcohol consumption. If you think back to the beginning of my presentation, I mentioned that chronic alcohol use also stimulates the dopamine and the opiate systems in the brain. So these were what was involved in the pleasure and the reinforcing effects of drinking alcohol. So this actually works against that to reduce those cravings and try to prevent the patients from drinking. These patients need to have failed attempts in quitting drinking in the past, but have high motivation to be abstinent for a while. So they must abstain from drinking or be withdrawn with medical assistance for several days before starting. It is important to note that these patients also should not be given to patients who are also dependent on opiates or those who need opiates for relief of chronic pain, because it's going to work against it. The opioids are not going to work. These patients also need baseline labs and monthly during the 4-month course. So this is contraindicated in patients who have liver enzymes greater than 4 to 5 times the upper normal limit. So this is important because, like I said before, a lot of these patients will ultimately have liver damage. So this might not be the right drug for them. It does come PO, which is a daily medication, or it can be given IM, which is monthly, which is better for compliance. But they have to be part of a REMS program if they're going to get the IM injections. This is just to increase awareness of the risk of serious injection site reactions. So the downfall of this is that it is cannot be given if they have severe liver damage. The next one I have is disulfiram. So this is a thiuram derivative, which blocks the oxidation of alcohol at the acid aldehyde step. So it's indicated for the management of chronic alcohol use disorder, but it cannot be administered until the patient has been abstained from alcohol for at least 12 hours and should never be given when they are in a state of alcohol intoxication. And this is because of the disulfiram reaction. So like I said before, acid aldehyde is actually what precipitates all those severe symptoms we think of when we think of a really bad hangover. So this is the flushing, the throbbing in head and neck, nausea, vomiting, diaphoresis, chest pain, dyspnea, hyperventilation, weakness, confusion, vertigo, all these terrible symptoms that we don't want anyone to have. But we actually use this reaction as a basis for these patients. So we let these patients know that this will happen. And it's kind of like a reinforcing fact, so they know if they have another drink, they will experience these terrible symptoms. A benefit of this, though, is that there is no renal or hepatic dose adjustment, and it is just one tablet once a day. So this is ideally if the patient has some kind of liver damage, you can give them this, but if the patient is at high risk of relapsing, we probably won't give this medication to them. Last, we have acamprosate. So this is an NMDA receptor modulator. The exact mechanism is not understood, but it does work by promoting a balance between GABA and glutamate and helps reduce withdrawal-associated distress. So treatment should be initiated as soon as possible following a period of alcohol withdrawal when the patient has achieved abstinence, and it should be maintained even if the patient relapses, which is different from disulfiram. This one, though, is renally dosed. It's actually contraindicated if their creatinine clearance is less than 30 mL per minute, and there is a dose adjustment if their creatinine clearance is 30 to 50 mL per minute, you give half the dose. It's not metabolized by the liver and not impacted by alcohol use. So that's kind of its stance away from naltrexone and disulfiram, but it is less effective than naltrexone and disulfiram. So these liver function, renal function, and their likelihood of relapsing are kind of the three things we take into consideration when we're deciding which one of these three medications we're going to give our patients. Lastly, resources for help. So patients, again, they're at high risk of relapsing. So we have medications, but they really do need a support system to also help them get over their addiction. So we have the Substance Abuse and Mental Health Service Administration, which has a national helpline and a website. There's also the National Institute on Alcohol Abuse and Alcoholism. There's the American Addiction Centers. These patients need cognitive behavioral therapy, and there are mutual support groups within the communities that also help substantially with these patients to overcome their problems. So in summary, alcohol withdrawal is a clinical diagnosis. It can present with a range of symptoms anywhere from just mild headache to delirium tremens, which is the most severe complication. In terms of medical treatment and observation, benzodiazepines are our gold standard of treatment, and we have to constantly reassess these patients for symptom management. It can cause systemic complications, mainly liver complications. We do have medications to reduce drinking and prevent relapse, and referral for help is needed for almost all of these patients as well. So I'll open it for any questions that anyone may have. If we don't have any questions, so I will be emailing everyone who is here in attendance 5 post-assessment questions. If you could just answer them and email me back, I will send you the CE code so you can get credit for attending today. But if there are no questions, thank you, everyone.